Well, good afternoon, everybody, and welcome, and thank you for joining this 45-minute training session on the NovaSure endometrial ablation system. This will be followed by a live question and answer session. So my name is Alan Blair, and I'm the Hologic Clinical Applications Specialist Manager for the UK. And my colleague Stacey Tatum, who you can hopefully see in the window, waving, will be delivering today's training session. I'm based in Glasgow, and Stacey is in Colchester. Stacey is part of a team of 5 Hologic clinical application specialists in the UK, whose primary role is to educate and train our customers on the use of our equipment. Now, the agenda for today is we're going to start off by just reviewing the landscape and then look at 4 key features that make NovaSure unique. We'll then review the important seating technique, which is how the array is actually deployed inside the uterine cavity. We'll then do a very brief review of some of the key clinical evidence and the latest NICE clinical review data. And then we'll look at NovaSure in the outpatient setting, because we know a lot of our customers are, under the current kind of COVID climate, are trying to move their NovaSure procedures from theatre into the outpatient setting, which already a lot of our customers do at the moment. We'll then look at some troubleshooting tips, and Stacey will do a review of actually setting up the equipment and everything like that, and look at some of the key things that might crop up and let you help problem solve them. And then we'll do a live question and answer session at the end. So for everybody who joins this session, a training certificate will be provided. If a group has viewed today's session sharing one device, so for example, if you're watching on an iPad or a laptop and there's maybe 3 or 4 of you looking at one time, if you could contact us via an email address, which I'll provide shortly on the next slide. If you give us your colleagues' names and the hospital you've watched from, we'll also provide them with their own individual training certificate, because at the moment, if one person logs in, we'll only have that one name. So please take a note of the email address and send us those names. And I'll also show you that email address again at the end of today's session. Now, if you do want to send any questions where we're going through the presentation and also at the end for the question and answer session, there are a couple of ways to do it depending on which device you're using. If you are using a phone or an iPad, all you need to do is tap on the screen and you'll see 3 dots appear. When the 3 dots appear, then all you do is just click on the Q&A and then type in your question, and we'll start to see them appear down the panel. If you are watching on a laptop, then you can click on the little question mark that appears at the bottom, and then a Q&A box will appear in the top right-hand corner, and again, just type in your questions there, and hopefully we'll be able to answer them at the end of the session as well. So I just want to make you aware, we are still working, we are available, the team are all available to help support you at this point in time, if it's on the phone, via a WebEx, and even if you do want us to come in to your outpatient department or theatre, etc., we are available and we'll work to your guidelines at the moment as well. But hopefully this session will be useful and will let you get some confidence in setting up particularly the NovaSure in this session. So just to highlight, the ukginsurgical@hologic.com is the email address that you would send any questions to beyond this if you just want to get in touch with us and get some support. Or if you do want to let us know your colleagues' names if they've shared one device with you. So ukginsurgical@hologic.com. Okay, so that's all the introductions over. So let's begin. And I just want to set the scene with NovaSure and give you the indications for the system itself. So the NovaSure system is intended to ablate the endometrial lining of the uterus in premenopausal women with menorrhagia due to benign causes for whom childbearing is complete. Okay, so that is what it's used for. But really to set the scene, particularly within the UK market as well, but certainly across the world, it's quite similar. We know that 1 in 5 women will suffer from heavy menstrual bleeding, so that is a big problem. And the consequences to not only the women's lives who are suffering with this, it does cost the UK economy, they say on average, 531 million just in days off a year. But we do know this is a big problem, and women sometimes take 7 years to get to the point where they'll have their end result, for instance, having a NovaSure procedure. They start their journey with a GP, it can take a long, long time to get to this end point. So if we can help show the benefits of this product and how successful it is, hopefully it'll quicken up that process for a lot of ladies who would really like to have a resolution quickly. And also, heavy menstrual bleeding is one of the most common reasons for hysterectomy, and that is a radical procedure to go through, and particularly under the current COVID situation, you probably don't want to be going into theatre at the moment, and if we can do procedures in an outpatient setting, all the better, and prevent a patient even having to have a hysterectomy in the first place. So NovaSure is the market leader in endometrial ablation globally, and is minimally invasive, so it's generally a very short procedure. It can be done in theatre, but more and more people are doing it in the outpatient setting, and generally it can take a 30-minute session from the patient arriving to when they leave, and they'll actually have the procedure. And on average, it takes between 60 to 90 seconds to actually have the ablation completed, so it is very quick. We know at 5 years, there's a 97% avoidance of hysterectomy published. And also it will almost immediately improve the patient's quality of life. They don't have to wait months to start to see a result. They will literally within days start to notice a difference, which is fantastic for the patient. Now, the product NovaSure has been on the market for 19 years, so it's well established. And as I say, it still is the market leading product, and it shows you just how good it is. And we've now treated more than 3 million patients globally. So we're very proud of the fact that a lot of ladies have managed to have this procedure done and have now got on with their life and are quite happy with the results. Now, for those of you who are familiar with the NovaSure itself, I just want to point out a few key features which are probably important, and you may already know this, but it's worth just pointing out. So what I just want to show you is the key thing from a dilation point of view is we have got a 6mm sheath here. So this is the sheath. This is 6 millimeters, so we want to dilate really up to a maximum of 6 millimeters. We don't want to over dilate the cervix. It's important we get a tight seal to help with some of the safety testing that happens later on. We also have this cervical seal here, and basically this seal here will be pushed into the external os to create a nice tight seal during the procedure, and the consultant will push their thumb onto here, and this will then slide up into the external os and create this seal. Another important thing is this blue front handle. It is blue for a reason, and that is because from a safety point of view, the consultant should only insert and remove the device holding the blue handle. They should not be using both handles at the same time or the back handle when inserting and removing. It's only the blue handle, so it's a key safety feature. And if you could remind the consultants, if you see them not doing that, that'd be really useful. So I want to give you an overview of just some of the key things that make NovaSure unique, and this is why we achieve the best results in the market for endometrial ablation, and it's based on these key features which nobody else can offer. So the 4 key features are: it is bipolar radiofrequency energy. The second one is a proactive cavity integrity assessment test. Feature 3 is a unique moisture transportation system, which is technically like a vacuum system. And number 4 is a scientific endpoint, and they all play a critical part in the success of the procedure. So just looking in a little bit closer to the bipolar radiofrequency energy, this video here is going to show you that loops of energy travel in and out the array at the end. So this gold threaded mesh is traveling in loops of energy in and out, giving feedback to the main controller. And what you'll see then is we start to vaporize the endometrium, and then we start to desiccate down into the myometrium. And then what you'll see is we have a slightly tapered finish, and I'll just put my pointer on. We have a tapered finish here at the internal os and also at each cornea. So it tapers in, and then we start to go to a slightly deeper depth of ablation in the body of the uterus. And another thing to note, it is bipolar radiofrequency energy. So what this means is you don't have to use a grounding pad like you would use for a monopolar system. The bipolar energy is coming in loops and it's coming back into the system. It's not going through the patient as such. So no grounding pad is required. So one of the key thing as well with radiofrequency energy is because we are working on the individual size of the uterine cavity for that patient, it is customized for each individual patient, so it is unique. It's not just one size fits all. So the consultant will measure the length of the uterus and the width of the uterus, and we'll input those figures into the controller, and it then works out what the optimum power level needs to be to deliver the most appropriate ablation for that patient. So as I say, it's not one size fits all. It will adapt to that unique circumstance for that patient. The second important thing to note is it has a proactive cavity integrity assessment test, the CIA test. Now, this can be the most challenging area of the procedure, and sometimes it can be quite frustrating for the consultants if they can't pass this test. I just want to explain what it's doing and why it actually is really important. And if it does fail, then the actual NovaSure device is doing its job, and it's doing its job well. So here what you'll see is we're actually pumping CO2 gas into the uterine cavity to do a check to make sure that there are no perforations. You'll see here we pierce the cavity, for instance, with an 18 gauge French needle, so just a tiny needle, so 18 French gauge needle, and the system will detect that there's a perforation there, so the gas is leaking. So what the system is actually looking for is wanting to hold that CO2 gas in the uterine cavity for which is going to reach 50 millimeters of mercury pressure for 4 consecutive seconds. If it doesn't hold it for those 4 consecutive seconds, the system will fail. Now, usually what's happening is we're getting gas leaking out of the cervix at the external os area. But we'll look at a few fixes with Stacey later on how to try and manage that if that does happen. But if you can't get it to pass, it does mean that potentially there is a tiny perforation in the cavity somewhere. You might not even be able to see it. But what we do know is the energy will travel down the path of least resistance. And if that tiny hole actually runs into potentially the patient's bowel or bladder, that energy will travel down that path, and we could end up ablating the bladder or the bowel, which is an adverse event, and obviously we don't want that to happen. So the system will not let you proceed to do the case until it's sure that the cavity is intact and there are no perforations. So it's doing a really good, safe thing for your patient to keep them from having an adverse event. The next one I want to look at is a unique moisture transportation system. And as I said, this is like a vacuum system. So what we're able to do then is in the cavity, you may have immediately beforehand done a hysteroscopy, so there could be some saline fluid in there. The system is not dependent on the patient's menstrual cycle, so there could also be blood in the cavity. What we want to make sure is we're pulling those fluids out of the cavity, because if you can imagine, if we're not pulling those fluids out of the cavity and we start to superheat the cavity as part of the ablation process, that fluid turns into a different form of energy and will turn into steam, and then we could lose control of the ablation. So again, this is why the NovaSure will give you the best results, because we can accurately control the depth of the ablation for each patient. So what I'll show you in this video clip here is the suction happening. So we actually suck the tissue onto the array, and this is better for the patient as well. They're not having that distension where maybe if they're using a balloon for the ablation, we actually distend. This actually sucks it down, so it's slightly more comfortable for the patient in that aspect. But also, just to reiterate how important it is to be able to pull those fluids from the uterine cavity. In the next slide here, what you'll see is 2 levers, and on the left-hand side is the NovaSure, and on the right-hand side is the system that doesn't use suction. So you can see initially we start to have this nice uniform depth of ablation coming down, but then if we look over to the right-hand slide, if we're not pulling that fluid out the cavity, what happens is we start to cause this steam energy to bubble up, and we're losing control of the ablation here. In comparison, at the same time, you can see here we've got slightly deeper onto controlled depth here. This is because we're pulling that fluid away and not allowing it to change energy into that steam energy. So again, another great safety feature. This is why we achieve some of the best clinical outcomes. So finally, we're going to look at the scientific endpoint. And again, this is just an amazing thing that has been developed for the NovaSure system. And what the scientific endpoint is 50 ohms of resistance. Now, what this actually means is the system is going to work, and as I said before, we have this array here, and I'll just show you on the screen. You can see the array here. When this is inside the uterine cavity, the energy is traveling in loops in and out of this array. And with this, I'll just show the video. When we insert the device, the array goes in loops in and out, and we know initially there's lots, it's a fresh tissue in there, so there's lots of fluid. And we know that from a conduction point of view, there's little resistance in that energy. So it travels in loops round through the patient's tissue, and it's like, yeah, no problem, there's not much resistance here. But as we vaporize the endometrium, move into the myometrium and start to desiccate that tissue, the resistance starts to increase because there's less moisture there. It's becoming harder and harder for the system to go through. So what the system is looking for is 50 ohms of resistance. We know that that is the optimum resistance to give the right level of depth for each patient. So the array is not all on and all off, it's actually selective. So some areas of the mesh, if an area reaches 50 ohms of resistance first, that will switch off, but everything else will continue until the whole array reaches 50 ohms of resistance. The maximum time that could take is 2 minutes. It will never go beyond 2 minutes. But this is also the reason why sometimes, if you've been in and have seen some ablations, they can be 45 seconds, they could be 1 minute, they could be a minute and a half. It can go anywhere in between in that time. And that is because that 50 ohms of resistance has been reached quicker in some of those patients. So it's just a key thing. So we know that the system is stopping when the optimum ablation depth has been reached because of that resistance. Okay, so that's the kind of technical aspect to what we're doing. Oh, I'll just move that on. So we understand now what's happening with the device. But another really important aspect to get right is the actual seating technique, and that is the technique of making sure when you insert the device into the uterine cavity that we are able to open the array without it getting stuck anywhere. So as I said before, the NovaSure it's not dependent on the patient's cycle. So sometimes the endometrium could be thickened, and when you do go in, that means there's probably not as much room for the array to open. So by doing this seating technique, which I'm going to show you, this allows the array to be fully opened so that the tips are not stuck in the tissue. And we'll look at the dial reading, and Stacey will show you this in a second. But also, we're going to achieve the maximum amount of surface area to be covered. We don't want to go back in and see some pink areas in there because the array has not been fully opened. So if we make sure it's nice and open, the patient will get the best possible outcome. So what I'm going to do, I'm going to pass over to Stacey, and she's just going to give you a close-up of what we're trying to do with regards to this placement to make sure nothing's getting stuck. Over to you, Stacey.
Thanks, Alan. So I think you're going to show some slides afterwards, but basically the seating technique is hold the blue handle. Once you've dilated up to 6 millimeters, you insert down and along the line of the axis of the uterus until you meet the fundus. I'm hoping you can see that. You then draw it back half a centimeter to give it room to open up, and you start to squeeze the handles together. You do that, but you do not lock. When you feel resistance in the handles, it will be when that little bit of plastic meets that bit of plastic, you start to do what we call the tap and twist. So you tap the fundus and twist, squeezing the handles the whole time until they lock into place. Once the device is locked into place, we just need to manipulate it inside the uterus. So we do anterior and posterior movements, lateral movements, or as we say the sign of the cross. Once that has been done, then the most important bit of that seating technique is what we call the pullback. So while it's locked, we pull it back, we watch our dial, and we pull it back no more than 0.5 of a centimeter. So I'm just pulling back now. You can see it moving, and if you can see, I've just pulled it away from the fundus. And what that's going to do, if it's caught anywhere, it's going to open it up so that it can flick open, and then you advance it back to the fundus. And as you can see, the dials move back, and I have a nice coverage inside my uterus. And then once that's done, they can push up the thumb tab and start the procedure.
That's great, Stacey. So just the dial at the end is to give you the width measurement. That's cornea to cornea. So that's what it's measuring inside the cavity. So when it opens up and springs up, that is the reading from cornea to cornea in there for this particular patient as such. But also, Stacey, could you just show them as well, if we go in and we actually have the tips stuck, what that would look like and how important, again, that pullback is?
Okay, so I'm just going to open my device up. So you can see there that it's opened up, but I've missed a little bit here, so it's embedded in the fundus. Now, if I pull, let me just pull that back so you can see the whole thing. If I pull back, watch the array inside the uterus. It just flicks open. My dial then opens up fully, and then I can advance it to the fundus, and then I know my array is completely open.
Fantastic. Thank you very much, Stacey. That's great. So I'm just going to come back to some of the slides, and the next slide is going to actually show you what the official seating technique would look like. So just have a look at this, and then we'll discuss that after the next video.
Using the blue handle, insert the device in line with the axis of the uterus until the distal end of the device touches the fundus. Withdraw the disposable device approximately 0.5 centimeters from the fundus. Slowly squeeze the handles together up to the point of increased resistance, but do not lock. Continue to slowly squeeze the device handles together while gently moving the device to and from the fundus and rotating the device 45 degrees clockwise and counterclockwise until the handles are locked. Once the device is locked, move the device using anterior, posterior, and lateral movements. To complete placement, slightly pull back on the device away from the fundus until the width dial reading reduces 0.2 to 0.5 centimeters. Advance the device slowly and gently to the fundus. The width should read greater than or equal to the previous measurement. Slide the cervical collar against the external cervical os using gentle pressure on the thumb tab. Keep the collar in this position for the rest of the procedure.
So basically that is the seating technique, and I appreciate sometimes just looking at that, there's quite a lot to remember there. But if you do want to have a refresher before you start a procedure, you could just go to Google or just go to the web and type in NovaSure seating technique, and this video should appear and you can have a quick look at that just to remind yourself. But also something we've created is a kind of a reminder of what it could look like in your head if you want to go through this step by step in a slightly simpler fashion. So the key thing is always advance gently in line with the axis of the uterus until the distal end touches the fundus. So just gently touch the fundus. The key thing here is just to retract back that 0.5 centimeters. We need that little bit of room just to allow the tips of the array to open. So you must pull back, and then what we'll do is we'll do that tapping and twisting motion that Stacey showed you. Then you'll lock the device. Then we'll cross, so anterior, posterior, lateral. Then finally, you'll look at your dial on the end, and you want to pull that back between 0.2 and 0.5. So just a tiny amount, just pull it back a little bit, watch the dial, and then gently advance back up to the fundus. So we're going to tap, twist, lock. Then you're going to do cross, anterior, posterior, lateral, pull back a little bit, then advance. And that is your seating technique. Okay. So hopefully most of the consultants and registrars and things using this will be following this guide. So just to be clear as well, what we do want to make sure is the fundus is being ablated as well. So what we don't want to see is if you've pulled it back and forgotten to just gently keep it up at the fundus, you don't want to have this gap appear. What we do want to make sure is the array is always touching the fundus just gently throughout the whole ablation process. Okay. So another important point just to be aware of is NovaSure, because it's been on the market for 19 years, we have a wealth of clinical evidence to support the product. More than 80 peer-reviewed clinical publications, etc. So whatever you're thinking of, you'd like to maybe know some more information about, I'm sure there's something on it. But a couple of things just to give you some guidance. A good starting place if you do want to look at literature would be looking at the Gimbelson 10-year review paper. That's examined 15 peer-reviewed publications between 2001 and 2011. And it looks at amenorrhea rates, patient satisfaction, and surgical reintervention rates following the NovaSure. But as I said, we have a scientific affairs department who are able to assist our customers if you're looking for a specific piece of information or something that's been published around the world. If you let us know what that question might be, we can ask them to source that for you and then send you that information. So, but as I say, there's a wealth of clinical information to support it. Another important point to be aware of is the NICE review, which took place in 2018. And a couple of key nuggets of information that came from that is that they looked at a network meta-analysis, which is the most robust clinical review with substantial publications included for various modalities. and looking at blood loss and treating heavy menstrual bleeding. So for the first one, 15 trials of 8 surgical techniques, which included an IUD, were included in the network for blood loss in women with no identifiable fibroids, with a total sample size of 1,664 women. And from those results, NovaSure was found to lead to significantly lower blood loss. And NovaSure had the highest probability of being the best surgical treatment for reducing blood loss as well. I'll show you the table as well, just to verify what we're saying here. It wasn't even just slightly, we're talking about significantly greater percentage, with NovaSure at 90.7% probability of being the best through all this range of treatments. Another area that they looked at within the heavy menstrual bleeding guidelines for the NICE was patient satisfaction. So 22 trials of 9 surgical techniques, including IUDs, were included in the network for patient satisfaction, with a total sample size of 2,719 women. NovaSure had significantly higher patient satisfaction rates than balloons, microwave technology, etc. And NovaSure had the highest probability of being the best surgical treatment for improving patient satisfaction. And again, I'll just show you that table, and you can see we were significantly greater than anything else at 48.7%. So if your patients are coming in, feel satisfied that this is a really good procedure for them to have, and they should have a good outcome when they're having the NovaSure procedure. And also, just to finish on from the NICE guidelines, I just wanted to look at the recommendation that's come in. And so in conclusion, comparing other endometrial ablation technology, it's clear that NovaSure has been endorsed as the best treatment to reduce blood loss and offer significant higher level rates of patient satisfaction. And what they've said then is, when selecting a second generation technique, providers should select one that is expected to deliver outcomes at least equivalent to those from radiofrequency endometrial ablation. And that is just a phenomenal statement for us, because it shows you that through all that analysis, that really, if there is a product out there in the market that's going to offer better results than that, we'd be glad to hear about it. But certainly radiofrequency is your benchmark, and you should not really be offering your patients anything less than that where possible. So just to give you some information on literature that we do have, which might help, as well as we have a brochure which has been created, which looks at the wealth of data we've got and some commonly asked questions that often come up. Things like, can I use it with patients with previous C-sections? What if they have large cavities? Can we access the cavity post-ablation and cancer detection, etc.? So this booklet in here, we have a PDF version and a paper version. We can send these to you if it's of interest. And this helps answer those questions and also gives some clinical information to guide you on those potential patients that are coming forward. We also have patient advice leaflets. These are free. All you need to do is contact your local representative, and we can send these into the department. Ideally, the patient should receive this at their consultation before they have the procedure, but certainly you maybe want to give this to the patient as they are about to have it, or at the end of the procedure, if they've not already had a copy of this brochure. So just ask us for it. So as I said at the start, we are seeing a lot of our customers asking about setting up NovaSure in the outpatient setting, for those that are not already doing it, obviously. And it definitely is achievable, and it's fairly straightforward. A couple of things we want to point out, just to make you consider, is generally, if you are going to do the procedure, hysteroscopy would be done right before the procedure on the same day. And it's important that if you are doing that hysteroscopy, have the fluid pressure at a low setting, because the higher the setting, the more pressure we're putting inside the uterine cavity. And they say about between 70 and 80 millimeters of mercury pressure will end up cracking the fallopian tubes. So that just weakens them for a short period. So then if you've done that at high pressure, we then go in and try and do this cavity integrity assessment test by pumping the CO2 gas into the cavity. Sometimes it won't hold the pressure because the fallopian tubes have been cracked, because just a few minutes before you've done this high pressure hysteroscopy procedure. So if you can, keep that low. Another thing to note is the patient can attend at any point in their menstrual cycle, so no pre-treatment is required. The patients are encouraged to eat and drink before the procedure, And it is important that we counsel the patients on what to expect from the procedure. It is important that they know that, yeah, there can be some discomfort in the outpatient setting, to expect it, but it is a very short procedure, maximum 2 minutes, but on average 90 seconds, possibly less. And if they know that, they can tend to bear with it. But what we're seeing is there are a variety of different techniques used to apply local anaesthesia, and they can range from Entonox, paracervical, intracervical, or the fundal block technique. And that whole range can make a difference just depending on the pain scores. And certainly what I can say from the Scotland perspective is they tend not to give anaesthesia other than the paracervical block. The patients generally tolerate it quite well, but it is important to select the right patient. But we are seeing fantastic, really low pain scores where our consultants are using the fundal block technique as well, and I'll discuss that in a second. We do advise patients take prophylactic pain relief 1 hour before the procedure, and they can take that at home. And the vocal local is really important here to keep the patient's mind off the procedure. So having your nurse just chat away about the weather and whatever's going on in their life just for that very short period of time can make all the difference to a successful outcome and a good experience for the patient. But as I say, it has been done a lot of these procedures, and we can give you a lot of guidance from some of our reference centres, and also do peer-to-peer training if required. Now, there are booklets and information that we can provide on providing local anaesthesia within this setting for the NovaSure procedure. We have a guide to paracervical intrauterine fundal block booklet, which contains different consultants' recommendations for what they would use for local, and it's a whole variety of different things. You can flick through and see one that you might prefer to do. And also we do have a video available, which is Martin Underwood at the Shrewsbury and Telford NHS Trust giving a voiceover on how he would apply the fundal block technique, so just to let you see that. And we also have NovaSure patient testimonials. So I personally went in and recorded some patients 15 minutes after they had their outpatient NovaSure procedure, and they talk about how there was really, minimal pain, just a little bit of discomfort, but pain levels are generally 1, 2, and we can show you that video as well if need be. And the clinical application specialist team like Stacey, we all have our own training kits where we can come in with dummy uteruses and help train the team on how to apply the fundal block if required, using the different types of needles, etc. And we have our own camera system and things to come in with that. So just shout on us if you need to have that support. We would be delighted to come in and give you that confidence to start doing these procedures in the outpatient setting. So now we're going to move over to Stacey, and we're just going to run through the setup and generally what would happen when you want to start from the beginning and build the NovaSure ready for the procedure to start. So over to you, Stacey.
Thanks, Alan. Okay, so I'm going to quickly take you around the back first. So when you're doing a NovaSure procedure, you're going to need the NovaSure controller, you're going to need the gas canisters that go with it, foot pedal, a plug, and your handpiece. So once you've plugged it in, I just want to show you around the back. You have your plug here, your on-off switch, and your gas canister for your cavity assessment. We always keep one spare so that we know, we eyeball straight away. If this one runs out during the procedure, we know we've got another one to hand. We don't have to go looking for it. We don't have to find an empty box and realise actually we haven't got one, so we have to abort the procedure. So always keep one safe, and just eyeball the date on it as well when you start, just to make sure your gas is in date. So turn it round and switch it on. It has its own foot pedal, and just to let you know, if you ever think that your foot pedal isn't working, if you do MyoSure, this foot pedal is interchangeable with the MyoSure pedal. So you can always, so if you've lost it, you can always pinch the one from your MyoSure. So I've turned the machine on, and it's just doing its little systems check. So you can't really see the screen at the moment, but we are going to show you some slides later, so you'll be able to, we'll talk you through those. So once I've switched it on, it's showing me details of what I need to do. So it's telling me the steps that I need to do pictorially. And there's a little question mark on the screen as well. So if I wanted these instructions in text, I would just press the question mark and it would tell me step by step in text what I need to do. And that will go in a loop until you catch up with it. But if you know what you're doing, you go ahead and do what you do, and it will catch up with you. So while that's doing that, your surgeon will be doing a hysteroscopy with your patient. And what they're looking for when they're doing that hysteroscopy is that there's nothing inside the cavity that's going to stop this array from opening up. So we're talking really about big fibroids or big septums. Whilst they're inside, they will need to do some measuring as well, because there are certain parameters that you shouldn't be doing the NovaSure with. So the first thing they'll do is measure from the fundus. So either using a sound or their scope, they will measure from the fundus to the external os. Okay, so they'll thumb that off, and I know that's 8 centimeters. So the total sound length should be no more than 12 centimeters. If it is, then you would be working with label. And then they will measure using their scope or their dilator. They'll measure from the internal os to the external os. I know that's 2 centimeters. So then you take the 2 away from the 8 to give you your cavity length. Now your cavity length can't be any smaller than 4 centimeters. If you try to attempt to do an ablation and it's smaller than 4 centimeters, you're going to end up burning the cervix, which is not good for your patient. So no more than a 12 sound and no smaller than a 4 centimeter cavity. Now, once your surgeon's told you that your cavity is bigger than 4 centimeters, you can go ahead and open up your device. So your device comes packed like this, and that should be stuck on top. And this is a non-sterile desiccant filter. So for the meantime, we just need to stick that in our pockets. We open this up. There is a little ruler in there that's holding it all down. And then this bit will be passed off to whoever's scrubbed and sterile. And then this will be passed off to whoever's looking after the controller. So that's at this point, you take out the sterile filter, you open it up, it has 2 little caps on it, they can just be thrown away, 2 little red caps, like this. Okay. You take those off, we can get rid of those. And then you add this in, there's a little gap in your tubing. It doesn't matter which way it goes, it's symmetrical. Just make sure that it's on there nice and tight. And then it can be plugged in to the controller. So hopefully you can hear that beeping, and a little message has come up on the screen to tell me that this is purging the line. The screen has changed, and what it's asking for is that the surgeon opens up the device outside of the patient. And what they want them to look at is that the array opens, it locks into place. So I don't know if you heard the click, but the array and the mesh is all intact, and my dial at the end is working. So when it's closed, that little red bit and the 0 will be at this little arrow here. And then when it opens up, at the moment it's saying 4.6. Okay, so now I know that if I go inside the patient and this doesn't open up, it's not actually the device. Also on the screen, there's a little message that says array position. When you open it up, that should disappear. So if you're looking after the controller, when the consultant is doing that, you just need to make sure that disappears. And then we know the device is fully working. So at the same time as the consultant putting in the length, which was 6 centimeters on the actual device, whoever's looking after the controller just presses the green length, and then you can input the length. Don't worry if you can't see the screen. We've got a screen to show you on a slide, and I'll explain. But you press the up and down arrows to put in the length that you want. It starts at 4 centimeters because below 4 we shouldn't be doing it, and the length goes up in increments of 5. So I've now got it on 6. To get the width, I need to insert the device into the patient, and this is where that seating technique comes in. So like we said before, we will dilate up to 6 millimeter. Then the surgeon holding the blue handle will insert the device along the line and the axis of the uterus. They would meet the fundus, pull it back about 0.5 centimeter and start to close the handles together. When they feel resistance, you do the tap and twist, squeezing the handles until they lock into place. You manipulate further by the anterior and posterior movements, or the sign of the cross. Then you use the pullback. So I'm watching my dial, I'm pulling back no more than 0.5, and then I advance it forward. Okay. If you have a tenaculum or falsalum on, you can give a little bit of counter traction. You push up the collar, and then the dial is going to give you the width of your cavity. So this little arrow here will indicate the width. So then that can be put onto your controller. It starts at 2.5 because below 2.5, the electrodes aren't far enough apart to fire up. So it says it is 3.9. So once you've typed in your length and your width, it works out the power that's needed to ablate that size cavity. Get your consultant to check they're happy with the numbers that you've inputted, and then you press the little green tick. They will hold their thumb up on the thumb tag and give a little bit of counter traction with their falsalum, and then they press the foot pedal. That is now pumping that gas in to make sure it's safe to add heat. If it passes, it will hold it for 4 consecutive seconds. It tries for 30. Okay. Let's try that again. Okay. live and
Yeah, sometimes the rubber.
I think I've put my falsalum in this one too many times. I've made a hole. I've got another one to try if not.
It's okay, we get the gist of it. I think, you know,
Yeah.
basically it would pass most times.
Okay. Let me just go on. I've got another one here. Okay. Hopefully this one will pass.
Multiple attempts.
I'm hoping the gas canister will run out now, because that'll be a teaching teaching thing. Come on. Might have to do my troubleshooting now. But once it passes, there'll be a green tick. You press that. The surgeon will press their foot pedal once, and that will start the ablation. Now, I used this one yesterday and it passed, so I don't know why it's not.
Sometimes with the training ones, they deteriorate as well if you've used them too many times. So, you know, the business that will happen.
Well, so yeah. So once it's done, then it will say procedure complete. The surgeon will unlock, pull back the cervical collar, unlock, holding the blue handle.
Just a second, Stacey. Just what's quite a good tip as well is if you are on outpatients, when you push down to unlock it, the patient can sometimes jolt. So just to apply a bit of pressure, squeeze the handles and then push down on the tab, and that's a much gentler way of releasing that, so the patient doesn't jump.
Okay. So hold the blue handle, pull the back handle back. It's a bit like a bow and arrow. And again, you probably won't be able to see, but there's a little message inside that says array closed. And that's telling you it's safe to use the blue handle to withdraw the device back down the cervical canal. And once you've finished, pull your device out and it goes in your shaft. That's it.
Great, Stacey, thank you very much. So just to show you some close-ups of the pictures, we have got this intuitive touch screen technology, so just everything's really on that screen, so keep an eye on it. And Stacey, you want just to explain what they're going to see here?
So once you plug your device in, this is the first screen you will see, and this is the one that's asking the consultant to just open up the device to check before it goes into the patient. And if you can see in the bottom left-hand corner, there's a little question mark. So if you wanted those instructions in text, you press that, and that would give you that back in text. And to go back to the pictures, there'll be a little cross at the right top right-hand corner. And then once they've done that, then you will just press the tick. So this is the screen that you input, the length and the width. So on the left there, you can see that that's the length. You tap the plus keys, and that will go up in increments of 5, and that goes to 6.5 plus centimeters. On the left, you can see the width. That starts at 2.5, because below the 2.5, we shouldn't be doing the NovaSure. And then in the middle, the machine will calculate the power that's needed to ablate that cavity to reach that 50 ohms. Check with your consultant before you press the tick to make sure they're happy, to just cover yourself really, make sure they're happy with the numbers that you've typed in. You press the tick, they will press the foot pedal. Just once, they take the foot off the pedal, and that will start that cavity assessment. So as you saw there, we said it holds for 4 consecutive seconds, but it will try for up to 30 seconds. Once that happens, there's another tick that you press, they press the foot pedal, and that will start the ablation. When the ablation starts, you can see on the screen now that there's a clock that will count down for you. So if you are doing this in the outpatient, and your patient does become a little bit more uncomfortable, and that's usually the last 20 seconds, if I'm honest, you can tell them how long they've got to go, and then they get it in their heads, and they're able to tolerate.
So it counts up the way, doesn't it? It goes from 0?
Yes, it goes from 0 up to 2 minutes.
But on average, 90 seconds. Hopefully, you'll hear the noise as well.
Yeah.
It starts to get closer to that finish point.
Sounds like a landing plane, we're told.
Yeah.
So on the next, this will be when the procedure is complete. It is going to give you the details of the size of the cavity, the power that's used, and the time that was ablated. And really, this should be a minimum of what you're putting into your patient's notes. We do have stickers for you. They're free of charge. And a lot of places will put one sticker in the patient's notes and one in a procedure book, but you don't need them, but they're there for you if you want them.
Perfect. Thank you very much, Stacey. We'll go through some troubleshooting hints and tips, but I know we're already on 45 minutes, and there was a couple of questions have already come in, so I just want to shout them out just now.
Okay.
Actually change screens for us. So one of the first questions come in is, would you recommend using a propeller quill to remove the fluid before starting the ablation?
So it's not necessary for all patients, but a lot of surgeons will do it. And that comes from when your patient has either a large cavity or an introverted cavity or retroverted cavity, and the fluid that you use for your hysteroscopy can sometimes pull. So it doesn't hurt to do it. It's not necessary for every patient, but yeah, I would definitely recommend it for those with retroverted and large cavities.
Perfect. Another one has come in just to clarify. It says, is 12 centimeters the entire length of the cervix or only the uterine cavity?
No, 12 sounds, so from the fundus to the external os.
Perfect, fantastic. Okay, that's first couple there. I'll just go on to some of the predetermined troubleshooting hints and tips now. So just to make you aware and remind you that the screen itself will give you indications as to what to try to do to rectify any issues, and you can always tap on the blue question marks, which you can see on the screen. If there's a blue question mark, that will take you into the instructions for use manual and give you step-by-step instructions as well. So just always have a look there, and you can always shout that out to the consultant just to see the system's asking us to try this and try that and go through the process. And there's what the IFU would look like, and you can just scroll up and down using the banner on the right hand side to get more information as you go along. So first question, is there an audible alarm when the CO2 gas runs out?
Yes, there is, and it won't shut up until you have replaced it and screwed the other canister tight enough, which is why it's always best to have a spare one on the back. It will also tell you on your screen as well, for those that have the touch screen, that you need to change your CO2. Okay,
thank you. Next one, during the procedure the CO2 runs out, do I need to stop the procedure to change the canister?
No, it's best to leave the device inside the cavity, and like I said, it only takes a few seconds to change the back canister. So unscrew, it's lefty-loosey, righty-tighty, and put the new one in.
Great, thank you.
You get rid of your canisters, usually in your shark spins, but just check your local policies to see where they want you to dispose of them.
Thank you. 3, failure to pass the cavity assessment test. What does this mean?
Right, this is my favourite question. This means it's doing its job. it means it's telling you that gas is leaking out of that cavity somewhere, and it is not safe to put heat inside. The majority of the time, that will be leaking from the cervix. Okay, 99% of your CIA failures will be leaking from the cervix, and we can troubleshoot that all day long. Okay, but sometimes once you've done all that troubleshooting, you have to assume that there's a leak from inside the cavity, and we cannot troubleshoot that, and rightly so. So yeah, but the potential reasons for it leaking out the cavity is you either have a very patchless patient, it's the cervix has been overdilated, sometimes the consultant lets go of the thumb tab, and that just pushes that back and it seeps out. It could be that you pinged open those fallopian tubes with too high on your hysteroscopy, or like we said, there could be a perforation in there sometimes, and it is very, very sensitive and picks up the hole the size of an 18-gauge needle.
Fantastic. Okay, so that being said, what can be done? And I'm going to put you on the main screen. Okay,
so if it is leaking out the cervix, we can try as many times as the surgeon sees fit to make sure, reattempt this ablation. So the first thing the machine will ask you to do is make sure you put in your desiccant filter, because sometimes we leave them in the pocket. It will then ask you to make sure that all your little filters are on nice and tight, and that your canister here that all the blood drains into is hanging vertically. Sometimes we like to put things over patients' legs. This needs to remain vertical. If you've tried that, then you can just attempt, if you have a valsalum or tenaculum, you can just adjust it to create that nice tight seal around the cervix. You can attempt the ablation again. If it's still leaking, sometimes you will hear hissing, sometimes you will see bubbles, but the majority of the time you're not going to hear or see anything. So you can add another valsalum or tenaculum either on the other side, or you can flop them over each other like so, or you can push it to one side and put one at the top, one on the bottom, depending on the surgeon's preference. So if it fails again, what we could do, I don't know if you've heard of Gelinet, it's like a waxy gauze, or even wet gauze does the same thing. Roll it up like a cigar, you pull the cervical collar back, you wrap it around, and then you push it up, remembering to hold the thumb tab. That acts like a plug, and that can stop the gas from leaking out. Your last resort, really, if you've tried all of that, lots of other surgeons do lots of other things, but you can use a purse stitch. And sometimes we have a conversation, they say, oh, well, that's a bit extreme, but actually a stitch that is in for 2 minutes maximum versus a hysterectomy, because that will be your patient's next step if you cannot pass this CIA. So and again, we've had conversations with consultants that said that they don't believe they would have to consent for the stitch because it's in and out in 2 minutes. So try the stitch, a purse stitch around the cervix with the device in, and that should help you pass.
Great, Stacey, thank you. We've had a couple of other questions come in while we've been chatting, and maybe I'll just answer them now. Will the procedure be affected if I increase or decrease the width? So I presume that must mean if you get a reading of, say, 4 as the width, but you actually make it more or less on the machine. I would say yes. You should not be changing. The width is the width. You should not deviate from whatever the dial is telling you, because the machine will select the power setting that is the correct amount of power for that size of cavity. And if you modify it beyond the way the array is already set, we could have over-ablated or under-ablated cavity as well.
Guidance of the machine, definitely.
Yeah, okay. Another one is the cavity length considered from, do you recommend to use ultrasound with NovaSure procedure?
Is this for, if it was so, no, you can do the NovaSure as it is, just with do a hysteroscopy first and then the NovaSure. We have talked around re-accessing after a NovaSure, and you can use guided ultrasound to help you reaccess a cavity after a NovaSure has been done, if your patient comes back.
Yeah, but I think technically we are saying you do not have to measure the thickness.
Oh, I see what they're saying. Okay.
Just that's my take on it. So.
Okay. No, if they're talking about, you don't need to measure the endometrial thickness.
Perfect. Okay. Yeah, because the technology will detect that 50 ohms of resistance we discussed earlier on, that sweet spot. It will detect if there's a scar there, for instance, from a C-section, like a transverse C-section. Then it will detect the 50 ohms of resistance will be there much quicker than anywhere else. So the array will switch off at that point. So you don't have to measure the thickness and worry about that. But as I say, we can send you the booklets as well, which give you more information on that type of topic. Is the cavity length considered from the fundus to the internal os or to the external os?
To the internal os.
Yeah, so the cavity is right. Yeah, we do that. Yeah, that's right. Okay. Can you do 3D ultrasound instead of hysteroscopy?
Yes, I suppose you could, but ultrasound isn't as I wouldn't say it was as accurate as a hysteroscopy and seeing actually inside. So I suppose you could to do measurements, but I think doing a hysteroscopy is probably more accurate.
Perfect. Okay, so we'll go back to our slide deck. Keep us on track. How many times can you do the CIA test before you would abort the procedure? So this is a failure of holding the pressure inside the cavity.
Okay. So in our instructions for use, it says reasonable attempt. So that then comes down to your consultant's clinical judgment, how many times they decide is reasonable. So it's clinical judgment from your consultant.
Perfect. Yeah. So clinician's decision will be made. The vacuum alarm is audible. What could be the problem?
There's either too little or too much vacuum or suction, and that's normally due to over dilation of the cervix, poor contact with the cervical collar and the external os, and your vacuum alarm will just alarm, so you will need to sort those out.
Can you show as well the vacuum port as well? While we're there, a lot of people want to kind of prod inside that, but just explain what that is.
So here's your vacuum, and sometimes it can get stuck. So you would just use a dilator to just push that down again. And historically, the NovaSures used to be vacuum packed. So as they sucked all the air out of the vacuum, out of the packet, it would just pop this out. So they used to just tap that in as a matter of procedure. It doesn't need to be done now, but I still see surgeons doing it. It doesn't do any harm. If they want to do that, it's fine.
Yeah, but it's not going to make any difference. No. Okay, perfect. Wait, no, just come back up.
And again, just to say, make sure that these vertical canisters are vertical.
Yeah, that's it. Make sure they're vertical. Perfect. So let's see. It's either too much or too little vacuum, poor contact between the cervical collar. The vacuum relief valve is stuck, as you've pointed out, and obstructions detected in the device or the connected tubing. So making sure it's all hung vertically is perfect. What can you do to eliminate the problem?
Just what we've been over, yeah. So making sure that your tubing is all in, your desiccant filters in, your canister's vertical, not draped over your patient's legs. Everything's nice and tight, and yeah, it should be okay.
Perfect. What do you press in the controller to cancel the vacuum alarm and reattempt the ablation?
So there will be a little enable key on there, so that will stop the alarm, and then you would press it again to reattempt the ablation. If you reattempt the ablation and you've checked everything and it goes off again, then you would need to take the device out of the patient. And if you wanted to reattempt the ablation, you would need to use a new device. If that one works, please don't throw this one away. Wrap it in your clinical waste bags. There are stickers, traceability stickers in these NovaSure boxes. Take one of those, put it on that plastic bag and contact your local representative. They'll be able to take this away or get it picked up and we'll check to see why it was faulty, and then we'll be able to replace it with a new one free of charge.
Perfect, thank you. If the array alarm sounds, what could be the problem?
So with the array, take it out. So with the array, it has the electrodes at the end here, and if they're too close together, then they're not going to work. So it could be that they've got caught somewhere. So sometimes a false passage is made when we're inserting the NovaSure. Sometimes it gets caught up in that thickened endometrium. Sometimes it gets embedded in the fundus, and sometimes it gets embedded in the cornua. So that's what it's telling you, that it's too close together to be able to work.
Wanda, could you show, just bring a close up so we can see the actual dial on the end and you squeezing, the difference that makes? So just tilt it to the side.
So, right,
further back, that's it.
Right, there we go. Can you see?
Yes, you squeeze one end, you can squeeze the tips, and you can see the dial is linked.
And if it isn't out of that red, you are not going to be able to go further in the procedure because they're too close together to be able to fire up safely.
Okay, perfect. Another question is coming. Can we do NovaSure on a previously ablated cavity?
So it is off-label from us, but I know surgeons that have, because they can get, if you can get back in, the technology, because of the technology and the way it works with resistance in the tissue, so it has been done, but you would be working off-label basically.
Yes, we just
if you can get back inside the cavity.
Yeah, but you should not do another NovaSure on the same setting as well. So if you're not satisfied, you decide to go back in. That is a no. Can't do that. Okay. Can you use NovaSure in cases of adenomyosis?
So yes, is the answer. Yes, and there is evidence to say that it isn't as effective for. So patients can come back, but it's still a really high percentage. I think it's, you know what it is, Alan? I think it's like 75%, 76% of patients still avoid coming back in the first 5 years. We need to check that, but yeah, we can send that out to whoever.
If you send us an email just with that question again on the email address at the end, we'll make sure we come back with some literature on that for you.
But yes, the answer is yes, you can do it. And most patients still get a very good ablation, and we have clinical data to say that it helps with pain as well. Okay,
perfect. So I've been through these.
So this is the what we need to do with the if the array alarm goes off and it's pinched somewhere, then the first thing to do would be to use the pullback. So again, I just want to show you what happens if it's stuck somewhere. So again, I don't know if that could be put on screen. So we can see there that the array is pinched. Is just outside the red. So I'm going to pull back 0. There we go. And I don't know if you saw that flick open and then that spin round, and then just make sure you advance it back up to the front.
Yeah, that's why once you've locked the device, it is important just to pull that little pull back between 0.2 and 0.5, looking at the dial, and that can make that pop out. Sometimes as well, when we do go in with the device, the uterus can contract. It becomes kind of in shock. And what we've found as well is if you just, even though you might be in the red zone initially, just chat to the patient, sit for a few minutes talking as best you can. And what a lot of consultants will notice is the dial then starts to move as the uterus starts to relax, and then you move into the safe zone. So you're out of the red zone into the white zone. And then once that's there, you can then punch the number into the machine on your width and then start the ablation. So don't abandon it right away. If you see you're immediately in the red zone and you've tried a couple of things, just wait, chat to the patient, try and relax the patient, and eventually that dial will hopefully relax and come into the safe zone. Okay.
And also, if you've tried the pullback and you've tried waiting, then you could try reseating the device again. Again, bear in mind that it could have contracted, but once, if you've tried that and it hasn't, then just check that your array is not damaged. So take it outside the patient and just make sure it's not damaged in any way.
Perfect. Okay. Now, we are over time now, just by a few minutes, but we'll keep on going. We've only got a few more to go. So hopefully you can hang on if you're still here with us. Oh, right, that's us. Question asked. So thanks very much. I hope that was a good overview generally. Now, just to finish off the session, I just want to say that we have already now completed a few different sessions on NovaSure, MySure, Aqualex, etc. We have another session running at this next Wednesday, but it's starting at 6 o'clock in the evening, and it's going to be looking at trying to fast start a see and treat service for hysteroscopy using the MySure, and we've got a couple of options, which is pretty simple, very straightforward, minimal fuss, that you could take into your outpatient setting and get some of your patients who would potentially have gone to theatre, have the procedure done in that outpatient department during the kind of COVID situation. And if it is of interest as well, we have fetal fibronectin webinars running. One is next week on Thursday at 6 o'clock in the evening, looking at quantitative fetal fibronectin, which is another one of our products. And there's a QUIP app, which is looking to help triage women in a threatened preterm labour. And we have a guest speaker, Naomi Campbell, which is taking place the following Thursday on the 16th of July at 6 o'clock in the evening as well. So please feel free to join us. We are recording all these sessions and we hope to have them online soon on a YouTube channel, but we can send all the attendees a link once that becomes approved by our legal department. So watch out for that. So finally, I just would like to say thank you so much for joining us today. I hope it was helpful and clear for the majority of it. Just to remind you, we are working, so if you do need to contact us, and if you're not sure who your local Hologic rep is, just email us at ukginsurgical@hologic.com and we'll make sure that gets to the right person and we can come in and see you if it's possible and safe to do so. We can set up a telephone call, do a WebEx like this, etc. to help you one-on-one. Also, for those of you sharing a device, like I said at the start of the session, if one person is viewing, if you have one device like a laptop or an iPad and there's maybe 4 or 5 people watching this session, we'll only have one email address and one name, so please email us at ukginsurgical@hologic.com with your colleagues' names and the hospital you watch from, so that we can then make them their own individual training certificate. And finally, I would just like to say, if you are looking for any additional resources around the surgical portfolio for Hologic, that would be NovaSure, MySure and Aqualex, then have a look at the website ginsurgicalsolutions.com. So just type that into your Google or whatever. And with that, you should be able to find a wealth of information, instructions for use, videos, etc. in that spot. So again, thanks very much for joining us. I hope it was useful and I hope you enjoy the rest of the day and hope to see you back in your outpatient department or your theatre very soon. Have a good day. Take care.